Hi everyone, my name's Amber and I'm the Senior Speech and Language Therapist at the Marlborough Centre. The Marlborough Centre is an 81-bedded centre within St Neots in Cambridgeshire. We have three separate services within our centre. We have Eden, our inpatient neuro rehab service, Bray, our long-term neurological nursing service, and Mayfield, our residential service for those living with dementia. We were early adopters of Root back in late 2018 for Eden, our neuro rehab service. Our neuro rehab service takes admission straight from hospital, generally after a stroke or another acquired brain injury. Anything acute and neurological like Guillain-Barré syndrome or myasthenia gravis, and spinal cord injuries. Typically, residents stay for 6 to 12 weeks and they're typically funded by local CCGs. When we think about use of outcome measures, it's useful to think about the clinical national guidance which is in place. So the RCP have national clinical guidelines for stroke. And in section 2.9, rehabilitation measurement, they mention the measurement of function is central to the rehabilitation process. It also outlines that outcome measures should be suitable and appropriate for the clinical environment. So are they measuring what we want them to measure? Are they appropriate for the clinical environment? Are they quick and easy enough for all staff to be able to do? A stroke service should also agree on the standard measures to be used. So are we using these measures as a standard? Do we have protocols for data collection? For example, where are we storing this data? How often are we collecting this data and what do we do with this data? And do we have protocols for more complex measures? For example, if someone doesn't quite fit within our usual data collection realms, what other outcome measures can we be using for that individual? However, the guidelines don't mention specific outcome measures. So some of you may also be aware of SNAP and UK ROC, which are two outcome measures which are designed for use within stroke and in brain injury rehab. So SNAP is the Sentinel Stroke National Audit Programme, and they collect a large amount of data about patients, but they mainly collect information on how often they're seen and for how long that person's been seen for. They don't really look at the person's level of function before and after therapy intervention, so it's more of a measurement of service provision rather than the effectiveness of the service. There's also UK ROC, which is designed to be used in all level 1 and level 2 rehab services, but most rehab services actually fall into a category of level 3, so it's not used widely. So in neuro rehab, we do have lots of other outcome measures we can use. We have our formal assessments, such as our comprehensive aphasia test, the Boston naming test, the scenario test, the Western aphasia battery. We have self-rating scales, such as the Communication Effectiveness Index, the Communication Confidence Rating Scale, the La Trobe questionnaire, and the Voice Handicap measure. We also have lots of quality of life scales, such as the AIQ-21, the SAQUAL 39G, Colibri, and the LISAT. But we don't have many across-the-board measures, such as the Bartel Index, the Modified Rivamede Index, or the FIMFAM. And so that's where Root comes in. So we complete Root for each admission requiring speech and language therapy input, and we complete it upon admission and upon discharge, but we sometimes do a midway score if that person's here for a bit longer. So we opt to use the direct entry into Root. So we keep all of our personal identifiers on an Excel spreadsheet, and we also use this Excel spreadsheet for more local audits. Outcome measures can have a powerful influence over a variety of things. We can use outcome measures to request and secure funding from local commissioners for an extension of therapy funding or for the provision of specialist equipment. We can also use outcome measures to demonstrate changes from admission to discharge in impairment levels, activity, participation, and well-being levels, and this is information that can be shared with the CCGs, with the patient, with their families, and with the wider MDT. We can also use outcome measures to demonstrate those who might not be benefiting from therapy input anymore. These might be individuals who have made minimal or no progress since their admission to a rehab centre. We can also use outcome measures to highlight a need for additional funding, training, or recruitment within their service. So if, for example, one impairment, such as dysphonia, had lower outcome measures than, say, aphasia, we might from that be able to highlight a wider service need, be that for going on external courses, completing in-team CPD, a wider service development project. And if there have been particular gaps with recruitment, this may be reflected within our outcome measures and will indicate that recruitment needs to be addressed in order to improve patient outcomes. We can also use outcome measures to more widely demonstrate the impact of our profession as speech and language therapists on patient outcomes. So, why do we like to use Root at our inpatient neuro rehab centre? So Root has a very easy and quick to use interface, so for new users it's really simple to get the hang of. Root also offers free online training, both for new users and for people wanting to recap on their knowledge of this outcome measure. They've also got information on there on how to improve your service's inter-rater reliability. The development team are really keen and really responsive via email, so they're great to get hold of if you have any difficulties with the reports or with the measure itself. We love that this outcome measure doesn't just measure impairments in isolation. So for example, if we've got a resident who's really impaired from an aphasia and an apraxia of speech perspective, they might not make huge impairment level improvements while they're with us, but they might make massive improvements in terms of their activity, their participation and their well-being. And this is really reflected within their Root scores. So these individuals might really learn to compensate for their level of impairment, and they might learn a lot about aphasia and brain injuries, which is where we see that change at activity and participation levels. And those are changes that we might not see in our impairment-based or our formal assessments. We love that it's clinician reported, so you can report it retrospectively. So if you have enough information within your notes, you can even go back to even an individual you saw several weeks ago and you can still fill out this outcome measure. We also like that it's not an assessment you have to do in front of the resident, and it's something you can do when you're back in the office. The measure is really sensitive to change, so it goes up in units of 1 from 0 to 5, but you also have a 0.5 measure that you can use if someone is in between these levels. It's really quick and easy to complete, so it only takes a few minutes to get it done for each individual. And once you're done, you get a really nice visual chart which compares your admission score to your discharge or your review score. So not only does this make it easier for the MDT or for patients and their families to understand, but it also looks really good at the end of a discharge report and saves you a bit of time in terms of the presentation. And online with Root, they have a lot of built-in data that you can bring out to analyse, and it also produces reports. So you can formulate reports from a certain time period in your service, but you can also pull out certain reports for individual residents or individual impairments that you've been working on. And Root also covers all of the main impairments that we see in an adult neuro caseload. So that covers aphasia, apraxia of speech, dysarthria, dysphagia, dysphonia, and probably a few more that I can't remember off the top of my head. And it's an SLT only measure. So unlike the FIM-FAM, it's not a measure which is usually completed by the MDT as a whole. It's completed just by the SLT, which allows us to really wave the flag for SLTs in our service. So to finish off, I just wanted to use a case example. So this Root screenshot is from a lady who had significant aphasia. She also had apraxia of speech. There was also some cognitive communication impairments. She also had dysarthria, dyslexia, and also dysgraphia. So this was all from a left MCA stroke. And the primary TOM scale we chose to use was the aphasia one, and the secondary was dysphagia. So I chose to use this lady's TOM score as I thought it really represented the changes which can be made at activity and participation levels, sometimes irrespective of impairment level changes. So when I redid this lady's comprehensive aphasia test, she made quite minimal changes in the assessment scores, but that didn't really reflect the changes which we had made with therapy. So this lady really benefited from communication partner training, and I think that's reflective in the participation and in the activity scores. So she also left us on normal diet and normal fluids without any real signs of dysphagia. And we also made some lovely changes to her and her next of kin's well-being. And that was mainly through communication partner training and aphasia education. We also felt like this lady's social circle really widened after a long period of not seeing family and friends whilst in hospital, but also due to her level of aphasia. Looking at this score here, I think that's really reflected. Whereas if we'd have just gone with her CAT scores, that change wouldn't have been reflected by the assessment. And so here I've included the scales used for root TOMS for aphasia. So you can have a little look at these. Maybe just pause your screen, have a little nosy if you're interested. And here's the activity one, the participation, and the wellbeing scale, which is used for the individual patient but also for their close family. And that's it. Any thoughts or queries, feel free to drop me an email. Thank you.